And I know from us all working together, you'll all be bursting by now to ask each other questions. So I'm going to go to David first, and then I'll come to you, Jes. So David.
There you are. So it's been amazingly heartwarming hearing these accounts, and essentially I've just been sitting here nodding along with so much of the stuff that we've heard, and particularly around the emphasis about how you actually turn an educational opportunity into real life learning. Because one of the things that I've seen, so I've started to support some colleges as they think about how they implement AI into their curriculum. And they've all come up with lovely bullet points of what people need to learn. But when you delve into the detail of how they're actually going to deliver that educational experience, what they expect their trainees to do, there is so much more to it than just putting words on a page and expecting people to know how to find those resources. With regard to some of the work I did around electronic health records, I came up with a little architecture about knowledge, training, learning and development, when knowledge was the theoretical underpinnings that support essentially your ability to problem solve any solution. The training is when you get you develop a narrow skill set acquisition which lets you complete a focused task. Then the learning is when you take that knowledge and the training and apply it to a real life, real world scenario with feedback from patients, from peers, reflection on your own performance. And the development is all the skills that you need around that, which don't feel integrated to that particular bit of education, but they're so important. So your ethics, your human behavioural sciences. And I think it's really important with any educational strategy, as kind of both, well, Jes, Sangeetha and Henrietta kind of outlined it, you have that really full approach. It's not about just producing a resource, it's about how we support a learner through that journey and that pipeline. And the lovely thing is it sounds like everyone on this call is engaged. So if we can try and disseminate that, that'd be really useful.
That's really helpful, and perhaps for another day, but I'm really interested in how we actually embed that as an integral part of the electronic patient record and the whole experience. And there's some fascinating work being done in a number of places, isn't there, whereby you can look at, the clinical journey through a day, and then say, well, you were looking at A, B, and C, and what it might be really good if you looked at a 5-minute podcast by so and so on X, or that there are these e-learning modules. There's something about making it real time and of immediate value, rather than the learner thinking, oh, I must pick that up one day and it drifting past. But yeah, interesting things. Jes, sorry, David, go on.
The last thing, just to come back with a one line with that, is that you're absolutely right. And the other thing that I think we've been poor at previously, which we can build in if we're building these new resources, is the evaluation of that education and learning. So I think we need to learn what works and what doesn't work, so we don't persist with false strategies for too long. And I think one thing that I've been interested in is how do we create the evaluation around these new learnings, because that will be so important to make sure it works for everyone and works well.
And you've definitely got a group of people around here agreeing with you. Absolutely. Jes, what was going through your mind as you were listening to colleagues?
Yeah, I think I just wanted to pick up on those themes of a knowledge base and really understanding what works and not going over old ground. So make sure that you evaluate what we've got, what data we're able to collect, such as the analytics that Henrietta mentioned, and then think about how that impacts upon how we can deliver a knowledge base. I mean, I've recently taken up the role of being a variant curator on one of ClinGen's working parties. So ClinGen is essentially a gene curation project, which is a big project undertaken by the NIH in the US. And the idea is to build this freely accessible, centralized resource that defines the clinical relevance of particular genetic variants for use in all areas of medicine. So that's ophthalmology, immunodeficiency, everything. And that connection, so being able to contribute to this huge knowledge base, but also connecting to international colleagues. We hadn't really contemplated doing this before in the same way, but actually the pandemic has sort of spurred us on thinking, well, international barriers aren't such a major hurdle as they perhaps were. And you know, we were able to discuss particular variants. We actually share our research. This is a complete anathema, a complete 360 degree turn thinking to how we used to have these traditional structures of adversarial research institutes, and how now we really share information and put it all out there in the public domain. I think this idea of having open free access as well is also vital for patients, and particularly in my field, diagnosis and treatment of rare disease, because it means that we can just collect all of that knowledge together, and it allows us to share it, and it means that we don't have to all be in our individual silos, and I think that's been really, really helpful, and actually a plus point of all of this.
Thank you. And just before I come to Henrietta, you know, some of the work we've been doing within HEE has been looking at an innovation strategy now, picking up some of the themes that have come through around speeding up, accelerating spread and adoption, the evaluation that needs to precede that, have been work that Henrietta and I have been talking about within the department, and I think that's an area where we can do more going forward, because there's a skills base around that, as well as an issue about choosing methodologies. There's a skills base about selection and conduct, both of the evaluation and of how you start to transfer knowledge, test it, and look for adoption. So that's work that you might keep your eye open for as well. Henrietta, please.
It was just a quick addition really to the conversation around evaluation, and the fact that we are beginning to look at evaluation not just as what works or what doesn't, but also from a value added perspective. So what value is it actually adding in terms of the strategies or the approaches that we are looking at using to educate our workforce? So I just thought I'll just throw that in.
I think that's really helpful too, and you know, there are all the circumstances that have arisen mean that we do need to prioritise where we can be most effective and help the most. Which I guess I'm gonna come on now to look at. So we had a year before COVID landed, and there were a number of external factors that might have come into play to help or hinder progress. And obviously COVID-19 is the one that we're referring to. But I just wonder whether you think there were any other influences that have impacted on your work as far as taking forward, on our work, as far as taking forward the Topol recommendations. Is there anything that stands out for you over the last 2 years, or is COVID the key piece? Sangeetha.
I think there's already movement, particularly thinking about the organisational development piece, due to NHS structure and reform. So things like general practice, the primary care networks, and the ethos of groups of practices working together, new roles being developed in primary care and being funded for and encouraging working in that way, seem to be that. And also with the ICSs as well, kind of collaborative working across a population, like to help us and support a population. It seemed to be the infrastructure was already going in that direction, and I think COVID has probably made people, in some respects, because the directions are coming straight from NHS England, it's meant that people can just get on and build relationships with the people they're working with to do the job, which is probably helpful for their future work. But I've been really impressed with how the NHS has come together over COVID, managed and set up things like mass vaccination centres. I think it's been amazing.
It's quite remarkable, isn't it? David?
I think it's quite interesting to see how organisations are structuring themselves with regards to digital technologies and learning, because I still think there's a hierarchy, both in terms of a personal hierarchy, and sometimes people get job roles, CCIO, CDIO, etc., and then they're seen as the gatekeepers, and that's a really challenging position, I think, for them to be in. And I think it's also a challenging position for the rest of the workforce, because it feels like there's a hierarchy there, which is quite difficult. If you want to innovate, if you want to improve the service, you have to kind of jump through certain hoops, and that's quite a difficult kind of game to play when you're within a trust. And it also means there's a huge variance across trusts. But I think there's also a hierarchy in terms of what people consider as technology and education, in terms of, I think the push for trusts and other organisation is also the most direct push, which is trying to improve what they see as their patient-facing service, which is then installing a new technology to deliver X improvement in patient outcome. And I think quite often education is the poor relation of that. So as we try and innovate and bring different digital technology in, both to support our workforce education, but also then educate around digital technologies, I think often that's quite low down in the kind of pecking order of stuff. And I think if there's any work we can do to try and highlight that to trust, that education and training in these things has got to be paramount, and there's got to be a strategy, then I think that would be something incredibly important. I still don't think it's there yet.
I think that's a very helpful observation, and I can see that colleagues, are taking a very similar view. Matt, can I ask you to contribute?
Yeah, sure. So, just thinking about the pre-COVID and the long-term plan, and saying about April 2020, we're all going to have online consults, or you all should, patients have access to the online consults. And I actually, my study went from before the lockdown to post the lockdown, and it looked at GP views to that online consult before and after, and it was so insightful in terms of them saying, well, we're going to put it on our website, but we're going to hide it down in a small corner. There might be a few come through, but we're really not going to promote it. To, oh rubbish, this is actually quite good, and it's actually making our life, it's helping us, it's helping patients. And we've got the headspace and the bandwidth to make this really work, to now where we haven't got the headspace, and that honeymoon period is over, and that education of how do we use it, there's that a bit of a kickback at the moment, I feel, and practices are certainly saying, right, we're not going to have our online consults 24/7, we're just going to have them on working hours because we're getting snowed under, or the wrong people are responding to them, and it's increasing our workload. So it's such a fluctuation. It's really important that we give the resources to this. And I have to say, I slightly disagree in that it's all about education and training. I think there's a lot about support and just in time, like Sue, you were saying, that just in time. You're struggling with this, well, this is how I did it, or they did it that way, and try that. So not always formal education.
So, rarely a silver bullet is there. And I wanted to pick up on the fact that there were other levers in place, because if we're going to be looking at taking forward all of those recommendations from Topol, that it is of real interest to see what a crisis drives. We've yet to see what sticks from the crisis in terms of behavioural change, and there were undoubtedly other levers already coming to play, as you've described, particularly in primary care. And I think it's important that we keep sighted of levers and what can we use to drive the change. So we've seen this big change in access to care through digital technologies. So what are your observations about the recommendations we made for citizens and engaging with citizens? Where do you feel that is? And I'll perhaps share a bit of information after you, but I want to know what it feels like for clinicians. What's your perspective on that?
May I say, for my patients who are generally in the 20 years to 55 years of age, it's been amazing. We have we're a national centre, so we have patients all across the country. They have immunodeficiency, so they have been shielding for the best part of a year. So they started shielding in February and have been housebound. And so it was really our only way of working out what's been going on. And it has been very, very useful for us to actually think about, right, well, actually what we have to do is just engage. You know, we have to engage with however best we can do this. And a little bit of what you were saying, David, that, you know, we sometimes the education and the training perhaps takes a backstage role, but sometimes you have to go in and test it out and see what's working and what's engaging, and what feels as if it's working. I think there are some caveats, and I don't think we have fully appreciated that yet, and perhaps the GPs on the call would be best placed to answer this. But I think from our point of view, we don't have very many patients who are elderly, and we don't have very many patients who aren't digitally engaged. And perhaps those that we are not really encountering. And there is, you know, this bias where, you know, we only really focus on what is in front of us, don't we? We all do that, and we have to use all of the resources generally for problems that we have in front of us. But from my point of view, I think it's been a real plus.
Thank you, Jes. But there's an alarm bell ringing now, isn't there, around the call? David, next to you.
I think it's really interesting. I think every service is different and needs to find its own way. My service is very much what it can only be done for the patient in a patient-facing way. You can't look after a neonate in intensive care in a home scenario and do that. But what we found is with COVID, we have found that it's significantly exacerbated some of the inequalities and inequities around the parents being able to visit, being able to see their children, because we've had to put in guidelines and restrictions on parental visiting. And quite often when you are firefighting a busy unit and a busy ward, as Jes said, you treat the people you can see first, which means that the people who engage less digitally, when they're particularly not at the cot side and everything else, they can tend to get forgotten about. And for us, being slightly emotive, it's such a crucial period for parents' well-being as well as the support and the bonding to the child. There is a real challenge with people using it. And across our staffing levels, we get people who get it and are quite happy to use those digital media to kind of contact and inform the parents. And we get people who are scared of using the technology and everything else. So it is hugely variable, and a lot of work has got to be done both around the patients, but also around how staff interact with patients using these things. It's really critical. Yeah,
absolutely. Matt, please.
I think it's certainly showed the power of PPGs and also supporting through digital nurse champions or through digital hubs in either in hospital or in general practices for people to just come in, young or old, doesn't matter, on dealing with their woes, on being able to access healthcare as best as possible. And I think it's just highlighted that. I don't think everyone's doing it. There are a few pockets of good practice, and that needs to just expand now.
From my viewpoint, looking at the Topol recommendations around the citizen and patients, we're going to take forward now a consortia of information provider type services are going to be working with the public over the next 5 years. So using the expertise of health knowledge specialists to work with other information providers, whether that's in prisons, public libraries, pharmacies, community pharmacies, and so on. So there is a big initiative coming from that end, focused on health literacy, because the digital literacy and the digital navigation skills are just the entry point to do I have the information I need to book an appointment? Do I have the information I need? Do I have the navigation skills to connect across to one of these services? And then if you share information as clinicians, do I understand this enough to engage? So there is a big piece of work, and there are initiatives coming forward, but I think we're all agreed there's a massive amount to do. So if we come now to those issues around organisational development, listening to people recently, there's a lot of discussion around the balance between people, process, organisational culture, and the tech, and increasingly hearing that maybe this needs to be balanced out pound for pound. And I think that was an observation we pretty much took away from the Topol Review, that 80% of this was about culture and OD and maybe 20% about the tech. So Sangeetha, would you first, having worked into that working group, how do you see this now, and based on this conversation too?
I think when we were kind of writing about the OD component in the Topol Review, there was nothing new that we were writing about. These were themes and theories that have been around for a long time. Having an open and inclusive, innovative culture, that's been, the aim for a long time for a lot of organisations. So I think when we were saying it, obviously the aspiration was there, but I think it was felt that lots of people were like, well, how can you do that? Because the NHS and the cultures in certain hospitals and practices so ingrained already. So how can you cause that? And I think in some ways, the destructive mechanism of COVID has meant that actually people are having to work in a different way. People are doing different roles. People have different skill sets. So someone who might be a receptionist might be the best in using the technology and helping the patients. So I think it probably is the right time to kind of approach that and kind of home that in. But as someone was saying before, it has to be done on an individual organisational basis, because it has to really come from the ground up and people acknowledge it, rather than someone at the top saying, yeah, we all need to be inclusive and innovative. But I do feel that one of the things that really mattered to us when we were writing that component was finding out what matters to people. So that the people were the staff and the patients. And I think because COVID's been so disruptive and we need to get things going, decisions have just been made for ease, or because we need to implement this particular technology. And perhaps we haven't done that engagement piece, which is probably right in this current climate. But as the pandemic lengthens and our way of working changes, actually we need to be having those conversations to find out what's working for people and what isn't, and help them kind of get involved in the change or the iteration of the next steps.
Thank you. And I think there's a plug here for the lessons learned type approaches. We're really right in the heat of this, and there is a lot to capture and a lot to learn. But we want to take that learning forward as actionable recommendations. And I think it is really important that there is pause for reflection. It takes us back to the evaluation of the work that's been done today as well. So that's worth us all bearing in mind. Henrietta, please.
Yeah, no, really good points made there, Sangeetha. I think it's bringing everybody along. And I'm just reflecting on some of the work that we are currently doing within the Digital Readiness Program, and how that's beginning to unpick some of the cultural issues in our various services. So looking at, for example, the Digital in a Day board training, which is very much looking at, the leadership training, and for boards to truly understand the cultural changes that's required to implement digital. So again, I think for me, it's the bottom up, is getting our workforce, the support workers, the practitioner, whoever is in the workforce, understanding or gaining those skills, but also having the leaders to create the environment, or at least allow people to be able to utilize those skills that they are acquiring, because some of the evidence shows that sometimes, you know, the barriers are that people do not feel that there is a culture of supportive innovation to be able to actually embed the skills. So apart from training, culture was identified as an issue in terms of implementing it. What we're also missing and beginning to have conversations about is, whilst we're looking at developing everybody's skill, so almost bottom up and the top leadership, there is something about the middle bit. So the people that are on the ground, understanding what implementation looks like and how they can support and bring other people along with them. So I think a lot of effort and a concerted effort from a number of areas need to come together, and appreciating leadership at all levels really to make this happen.
Absolutely, and as I head to colleagues, I think as you were saying, Sangeetha, when you were putting that work together, that there's a lot here about the overlap between change management that we've talked about for many years, the quality improvement skills, the knowledge transfer pieces. They're all part of the digital leadership as we look to make these transitions. I'm going to come to colleagues to add to this part of the conversation, if I may, first to Matt and then to David, and then I'm going to come to each of you to give me your takeaway from today. What's the thing that you has most resonated with you, and perhaps what one thing are you particularly going to take away to do? But we'll just round off this part of the conversation first. So Matt first, if I may.
Sure. So I just wanted to really emphasize Sangeetha's point about that the non-clinical workers and how important they are, and that recognition of you don't just, so sorry, I always go back to general practice, but that's my field of view. So while you've got the partners and they're the main innovator and enthuser of the practice, we all know that it's the reception staff that are helping the patients day on day and just fixing the problems on the ground. And I remember you saying, Sangeetha, that there's no tool that's actually used on the ground. So we mentioned about the NASCAT tool, and that's probably the best tool we've got, but it's actually not been, how well has it been used practically? Well, I came across a mnemonic called Tool Team Routine by James Shaw and team, and it's just such a simple phrase, but actually it makes you think. You're implementing a new tool, who's going to be involved in it and how's it impacting their routine, to then just make sure you've got everyone on board and can help them, if there is a big change, help them to make that change.
Thank you, Matt. We'll take that one away from today. David.
I think it's really interesting about the different approaches you have to have about top down, getting the board involved so they understand some of the challenges, versus bottom up disruption. And I do think that the bottom up disruption sometimes in this can't be underestimated. We know that there are people who are going to fear change and actually aren't going to be able to follow kind of board direction and strategy and everything else. And actually sometimes just trying to focus on things which might actually work for the workforce. So taking the ground level workforce and actually producing something that they're really proud of, that they get hold of and run forward themselves. And I think this strategy potentially hasn't been employed enough in terms of around some of the tools that we use for digital, around some of the education that we put around digital, about literally, rather than waiting for the board to do something or commission a big body of work or anything else like that, just finding stuff that works. In terms of, as clinicians, we've all seen the power of what happened when people were initially using WhatsApp messaging, and then it got turned into different medical tools for actually messaging between different kind of patient groups or different kind of clinical colleague groups, and how powerful that's been. And I think similar revolution needs to happen around the education for these technologies and how we train our workforce. I think if we make it Statman training, if we make it board directed, then I think it's going to lose a lot of the design functionality and people aren't going to engage as they should. If we make it something like an iTunes that works for people on every behavioural level that people can own, then I think that's going to be far more powerful.
Thank you, David. Really interesting. And I'm just going to make a plug for another old-fashioned tool. It's not an old-fashioned tool, but the health and change model, you know, as we're taking forward these implementations, reminds us that we need some shared purpose at the centre, which definitely is part of organisational culture, but then a whole load of dimensions around it, from leadership to spread and adoption, but also our measurement and evaluation, because that gives us the ability to persuade others and take us with us. So, you know, really simple visual tool, but you know, like the mnemonic, sometimes when you're there in the heat of needing to make the change in an actual environment, some of these tools are really helpful. So worth bearing in those in mind too, but that underpinning educational strategy that takes it all into account as a, you know, no magic bullets, David, I think is what we usually say. So I'm going to come to everyone and ask you to give a final comment. If I can come to Henrietta first, please.
Interesting discussions, and good to have been part of it. I think for me, it's what we are saying here is it's messy and it's complicated, but we have done quite a lot, and obviously COVID has accelerated some of the work that we would have done. I think there is more to do, and bearing in mind that as we do it, we are conscious of the people that we are not seeing, to make sure that we are not leaving anybody behind.
Thank you, Henrietta. Jes?
Yeah, I mean, I think it's such an interesting discussion in terms of organisational development. I think my thoughts are about what it is to be a frontline worker. That phrase frontline means different things to different people, doesn't it? But actually, it means that you're standing in front of a problem, whether that's a clinical problem or a problem with engagement with digital technology, and really you can understand what it is because you have to engage with it, you have to troubleshoot it, you have to work out what's going on. And that concept that you've mentioned about bringing people with you and understanding, so you know, you're the one that's standing in front of this particular problem. How are you going to solve it? How are you going to make it better? And thinking about improvement and improving the service, both by tackling and causing organisational change.
Thank you, Jes. Sangeetha, you're on mute.
Sorry. It's been great being part of this conversation and thinking about this in particular. And I agree with the points made already. So I was thinking about who am I not seeing in clinic? Who can't get a telephone appointment or can't get an online thing submitted of their problem? So I think that will be something I'll take away to think about. And certainly thinking as we move forward to the evaluation of what we're doing. So is it serving us, and what can be iterated to make it better? And I guess the final thing for me is just reminding myself that everyone and anyone can lead change, and actually the people that we serve, our patients, our students, we should be encouraging that ethos in them.
Thank you very much. Matt?
It's just great to be amongst like-minded souls, and I feel like you guys really helped up my game when we were on the Topol Review and have helped move things forward, so thank you. I think what's come across is just one thing is about empathy and not technology, and if we always keep that in mind, then we should always do the right thing, and not just empathy for patients, but empathy for staff and our well-being, and empathy for the system.
Yeah, I think that's absolutely key and speaks volumes into the current situation, doesn't it? David?
For me, I think my learning point over the last kind of 2 years, which has kind of been echoed today, is that I do think in many ways the world has changed. And I think the health system that we work in is still a slow moving dinosaur in a kind of world of fast moving change. I think there are a lot of different things we can now leverage now, behavioural insights, the newer kind of cognition behind how people learn and everything else. And so I think the time is right for change. I still think the principles behind the Topol Review are absolutely right. I think the recommendations by and large are bang on, but maybe the tools that we use to bring those recommendations about just need a subtle change. And I'm not sure there's the system understanding of that yet. I still think many people want it to be the kind of same system, same strategy with just a couple of tweaks. And I think we need to push for slightly bigger change than that. I think there are new tools that we can use, and I think they need to be deployed sensitively and with evaluation. But I don't think we should be scared about being quite bold in how we try and change things for the future.
I think we personally, I welcome that, and I can see that on the face of colleagues. So as I bring this to a close, I think one of the things that at a really simple level, one of the things we did with the Topol Review was we made recommendations for the patient and the citizen, for the healthcare professional and for the system. And I think those lenses are still really potent. We talked a lot about having compelling, the patient at the centre, compelling, persuasive evidence, but real world evidence. And we talked about releasing time for staff, and I think those fundamental principles totally stand the test of time. So for me, I think the things that stand out are much about engagement with staff as well as with citizens and patients. And I'm thinking about the new generation coming through as they're impacted, as COVID is impacting on their schooling too, and around what that means for how we need to engage with them, as how to help them engage with healthcare and health services going forward. So I think there's a lot to be done on all three levels. It's been I use this word truly, it's been a joy to reconnect with you. It was a top team delivering the Topol report, and it's been an absolute pleasure. I thank you all for your time this session today. Thank you.